Dear Chairman, dear colleague, thank you very much for your very kind invitation and the opportunity to present here the results of our study about the integrated approach for refractive errors correction in keratoconus patients. In our institution was elaborated and successfully used the sequential tactics for the keratoconus treatment in different stages of this process. And in case of form first keratoconus, we just observe the patient during the dynamic follow-up. And the first stage of the keratoconus, we usually perform the UV corneal cross-linking in case of the progression of this process. The next stages which demonstrate the ectasia requires the implantation of the intracorneal ring segments, and in case of the symmetrical ectasia, we usually perform the implantation of the two segments. It looks like here. In case of asymmetrical ectasia, we usually implant one segment in the area of the most ectatic area, and 1 year up post-op, it looks like on the right slide. And the eye, it looks like here. And after that, we also perform the UV corneal cross-linking. Next stage will involve all corneal layers, requires more aggressive tactics, and we usually try to perform the deep anterior lateral keratoplasty. And in case when we have the high drops of scarring of the all corneal layers, we perform penetrational keratoplasty. These tactics allow us to cure or stabilize keratoconus process. But what can we do with refractive disorders? This is a very difficult problem, and we try to decide it the following way. In case of stable keratoconus of stage 1 and stage 2, and in case of rigid contact lens intolerance, and we perform the PRK for the refractive errors correction. It depends from which kind of topography we have, and in case with regular cornea, we perform the conventional transepithelial PRK. In case of the high irregularity of the cornea, we perform topography guided procedure, but maximal ablation depth should not be more than 15 microns. These results shown that 1 year post-op we have a significant increase of the uncorrected visual acuity, the significant decrease of the refractive errors, and mean ablation depth is about 40 microns in all groups of the operated patients. For this period, we operated about 85 eyes, and maximal follow-up period is 5 years, and no cases of keratoconus progression has been detected. In case with the native lens opacification, we perform the pseudophakic toric IOL implantation. It's well known that it's a very difficult problem to calculate the power of the toric component of the IOL due to the difference between the visual axis and axis of maximal refraction of the keratoconic eye. And usually some surgeons see the hyperopic shift of the post-op refraction. So at our institution was elaborated the correction factor for the A constant, which allows to improve the predictability of the refractive result. In case of the when we have the corneal transplantation, and in case of post-keratoplasty refractive errors, we perform the PRK or LASIK due to conventional or topography guided algorithm. Well known that post-keratoplastic eyes have a lot of specifics which can be the cause of the high rate of complications in case of the performing such procedures in post-keratoplasty eyes. When we analyze the reasons of the complications and try to find the corneal predictions factors which can be the reason of these complications, we detected that in some cases it may be the severe thinning, local or total thinning of the cornea after keratoplasty, low density of the endothelial sites, incomplete fibrosis or with epithelial vacuoles inside the scars, absence of the reinnervation of the corneal transplant, low extracellular matrix transparency due to the scarring of the central of the transplant, Bowman's membrane dystrophy, high rate of the corneal irregularity, and high rate of different stages of the eye dry syndrome. And we elaborate the corneal-based tactics for post-keratoplasty ametropia correction. In case when we have no severe pathological findings corneal, we perform LASIK or PRK according to the optometric parameters. In case when we see the Bowman's membrane dystrophy, we perform PRK, transepithelial PRK, and in case when we see severe corneal findings, we don't perform any corneal procedures. This principle allowed to operate 112 eyes, and 1 year post-op, we see quite good and predictable refractive results. And so, in conclusion, I'd like to tell that we elaborated and clinically approved the integrated approach for refractive errors correction, which allowed to reach the visual rehabilitation of keratoconus patient. Thank you so much for your attention.